Hello, everyone. We are talking about fluids and electrolytes today. So I put this on the first slide. Let me go to slideshow here so you can see it better. So this is how you would write your electrolytes and also CBC results, but I'm not really focused on the CBC today. We're talking about the electrolytes here. So whenever we call this a fishbone, whenever you're writing like shorthand on notes or something, this would be how it's written. So sodium is up on top here, the first one, potassium is under it, chloride is next, then bicarb is under it. Then BUN and creatinine, and then glucose is in the tail of the fish. Excuse me. So if you see this diagram, and a lot of computers will do this diagram too, so EHR will do it as well. If you see this diagram, then you immediately know what each one is. So I do want you to know the fishbone. So if I show you a picture of the fishbone and I say, what's the sodium level, you'll know it's this number here. Now, as you get a little more familiar with electrolytes and labs, you can almost pick out which is which because sodium levels are like 135 to 145. So that's going to be this number. Potassium levels are like 3.5 to 4.5. So obviously, if you have a sodium level of 3, you're dead. So you know that's not the sodium level. So as you get more familiar with these electrolytes, you can usually pick out which one is which. Chloride again is a relatively larger number, and then bicarb is a very small number. And usually creatinine is less than 1, sometimes a little over 1, depending on kidney disease, all of that kind of stuff. So you can kind of just glance at it. I would suggest just reviewing, maybe if you're working in a hospital or something like that, and you have access to these fish bones, you can kind of review, or you can go on the internet and they will have examples of them and you can review that too. But you should be familiar with this fishbone. This is for CBCs, white counts, hemoglobin hematocrit, and platelets. It's a little, to me, a little easier to figure out because hemoglobin, of course, is 1/3 of hematocrit, and that's why it's over like this. But that's a different lecture, that's a different day. So we're just focused on the fluids and electrolytes. So here are our objectives. So we're going to talk about the fluids first, fluids in the body. So most of what the fluid is in your body is water, and 2/3 of your body's water is intracellular fluid. So it was in the cells. It is in the cells. So most of it is in the cells. It maintains the shape of the cell. 1/3 of the water obviously is then out of the cell. And out of the cell, there are two main compartments. There's interstitial fluid that is basically what is between different organs. There's lots of different kinds of interstitial fluids. And then some is intravascular fluid. So it's not in cells, it's in your vascular system. So it's held in a particular body system, but it is not free flowing throughout the body. So there's transcellular fluids. There is pleural, that is your around your lungs. Synovial is in the joints. Peritoneal is in the abdomen. Pericardial is around the heart. Intramuscular is within the muscles. Saliva, we all know what saliva is in your mouth. Gastric juices in your stomach and intestine. Bile in your intestine. Pancreatic juice from your pancreas, obviously. Ileal is in the ileum of the intestine. Cecal is within the cecum into the large intestine. Cerebrospinal, obviously, is in your CNS, and then sweat. Most of these stay within the body. Obviously, sweat does not, that is excreted from the body. So the smaller the child, the higher percentage of fluid to body weight. That's why if you have if you're worried about a patient being dehydrated, the one you worry most about is a newborn baby because they have such a high percentage of water. So we all know, or maybe you don't know, but most people know. I'm gonna turn my light on here. It's starting to get dark in the room here. Um, Most of us know that a newborn will lose weight initially right after birth, and it's all water. It's all water that they're losing. And they lose it by several different means. They lose it through urine and stool, but they also um, lose it through insensible water loss, or if you look down here, through the skin and lungs. So as you exhale, you're exhaling a mist or a fluid, and also you're losing it through your skin. So babies have a higher surface area to body weight, so they will lose more water easily. So it's not unusual. Actually, we want newborns to lose water. Um, because if they don't lose that extra water, then it accumulates around their lungs and we have some issues with breathing. So we do like them to diurese after birth, and some babies will only lose a fraction of what other babies will. Some babies will lose a significant amount. So they are the ones that we worry most about with dehydration. And then as you get older, it's less likely of dehydration quickly. You really have to go quite a while without fluids to become dehydrated. The more obese a person is, the lower percentage of body fluid to weight. So that's why we encourage people that are obese to drink a lot of water because they just don't have as much water per their weight. Intake of fluids, I'm sure you all know this, drinking fluids, ingestion of water and food, and then also oxidative metabolism. If you remember, we talked a little bit about cellular metabolism, and it needs oxygen, and what the product of oxidative metabolism is ATP. That gives us our energy. So oxidative metabolism also gives off CO2. It takes in oxygen, gives off CO2, but it also gives off water. So that's one way we get water is by that chemical process. Loss of fluids, renal excretion or urine, stool, and then, of course, vaporization from our skin and lungs. And that's called insensible water loss. And we call it insensible in that it's hard to measure. You can't really measure how much fluid you're losing by breathing or how much fluid you're losing through your skin. Obviously, we worry about, people who breathe really fast or panting, you're losing more water that way, but it's insensible. It's a small amount. It's not really measurable, and that's why we call it that. So how does water move in the body? So water movement moves between the intracellular and the extracellular. So it's both ways. It's moving. And the movement of water is osmosis. So osmosis is water movement. Some people will say diffusion, and diffusion is not water movement. Diffusion is solute movement. So your electrolytes are moving in diffusion. Osmosis is water movement. So it moves through what is called aquaporins, or these are channels in the cell membrane, and that allows water to move in and out in that protein there in the membrane. So we looked at the membrane in our first lecture. We said there's these channels, and one of them is aquaporins that allows water movement. So you have to know the osmolarity of the fluid or the inside a cell or inside tissue, and that is the number of osmoles of solute, again, solute, the electrolytes, those kind of things, proteins, all of those. Anything that's not water is a solute per kilogram of water, and that gives us the osmolarity. And this is really important when we talk about medications or, certain foods. So if we have a medication that has a high osmolarity and you swallow the medication, then it will pull water into where that high solute concentration is. And this is really important when we talk about IV fluids. So if you're writing orders for IV fluids, you have to keep in mind the osmolarity of the IV fluid, because if the osmolarity is too high, it will pull water into the vascular system. Sometimes we want that. Sometimes we want to pull water away from tissues, maybe through edema or something like that. We want to pull that water back into the vascular system so it can be excreted through the kidney. But most of the time, we don't want that. And so, I work in the newborn intensive care, and the osmolarity is huge there because these babies, we already talked about, they're at higher risk for dehydration. So if you give osmolarity, high osmolarity through the IV fluids, you're going to pull in more fluid and it's going to be excreted. And babies' kidneys don't, we'll talk about kidneys later, but babies' kidneys don't do a good job of retaining water when it needs to. So they will lose all that water and then they become dehydrated. And we'll give them IV fluids and we're making it worse because we're pulling more fluid in. The same thing with taking high osmolarity medications. So if you take it orally, so if you take a medication in the stomach and it pulls water into the intestine, what happens? Well, you either have diarrhea because it leaves with all that extra water, or you're vomiting because you have all that extra fluid in your stomach. So, um, that's why a lot of medications are buffered in this way, that it buffers out that osmolarity. Um, I look at my own medication and I'll see like, maybe a tiny pill, say 25 milligrams, and then a bigger pill will say 5 milligrams. Well, it's because of the buffering that is in the pill to prevent that osmolarity when you swallow the medication. Sodium is most responsible for osmotic pressure in the extracellular space. So sodium levels in the extracellular space are very high, and it's responsible for the osmotic pressure. Potassium is responsible for the osmotic pressure outside the cell, so in the intracellular space. So pressures that affect movement of water in the interstitial space. So there's four different ways. There's the capillary hydrostatic pressure. This is basically your blood pressure, and that moves water from the capillary to the interstitial space. So if you have a high blood pressure, it is forcing more water out into the interstitial space. So we think of, people with high blood pressure might have trouble with edema because the fluid is being pushed out into the interstitial space. Capillary oncotic pressure, the increased osmolarity moves water from the interstitial to the capillary. So if we have a lot of fluid out into our body, it can be pushed back into the vascular system by the capillary oncotic pressure. Interstitial hydrostatic pressure, this moves water from the interstitial space to the capillary as well. Hydrostatic pressure is when you are the movement of the hydrogen ion. Interstitial oncotic pressure, this is increased osmolarity from the capillary to the interstitial. So you see that there's two that are moving water from the interstitial to the capillary and two that are moving from the capillary out into the interstitial. So that's how the body is regulating the fluid in the vascular system versus fluid out in the interstitial spaces. So we talked a little bit about edema. So edema is accumulation of fluid in the interstitial space, or swelling, basically, is what we're talking about. So I'm sure as a nurse, you've dealt with edema on patients, and you've probably know how to um, grade edema, if it's pitting or not. So typically, the edema can go anywhere. But it's important to note where it's located, whether it's generalized everywhere or if it's in a particular area, such as the feet and ankles. And why do we always seem to have it in the feet and ankles? Well, because we walk, because we sit, right? So the feet are the in a dependent position. Especially if you're sitting, you're not moving, there's no pressure from the muscles pushing the blood up the vasculature, and that way that fluid will pool in the feet and then it will move out into the interstitial tissue. So that's probably the most common place we would see edema is in the lower legs, ankles, and the feet. So the mechanisms here, we have increased capillary hydrostatic pressure. So we have pressure from the inside of the vasculature moving water out to the interstitial tissue. So we have this by venous obstruction, so we can't get the blood flow back up to the heart, or by sodium water retention. So it depends on if we have a high solute concentration in the tissues and that moves the water out, or we can't get the water out to the through the kidneys, so it pools down there. Excuse me. So decreased plasma oncotic pressure. This is a loss or decreased production of plasma albumin. So albumin is very, very important in the blood. A lot of things attach to albumin and then are excreted from the body through the use of albumin. So albumin keeps our oncotic pressure at a certain amount in the blood. It it increases the solute concentration and that will pull water in to the blood. Well, if we don't have albumin for whatever reason, we will we have a lack of solutes and that therefore the water is moving out to the tissue. Increased capillary permeability. So if you have leaky vessels, the water is moving out as well. This can happen in inflammation. This happens, we'll talk a lot about inflammation, but inflammation, the vessels become leaky because white blood cells, immunoglobulins, other things need to get to a particular site. So the vessels become leaky and that moves out. Well, as those are solutes. As those move out, water follows. And so you have that leakage. So that's why, if you get a bug bite, it swells because the vessels around there are now leaky and the white blood cells, other inflammatory response mediators are moving out into that particular tissue, and water just kind of follows along because it's changing the oncotic pressure. So let's focus now on the electrolytes. These are electrolytes we're going to be talking about. We're going to talk about these more throughout the semester. I don't care if you know the elemental number, I don't know why you would need that unless you're working in chemistry. You don't need to know the weight of the elements either. You do need to know the abbreviation of the elements as well. So that's why I have the little pictures here. I am almost sure you know all of these already, but just in case you don't, there they are. So we're talking about water balance. So balance is obtained through interactions among sensory organs, through the antidiuretic hormone and the kidney. We're going to talk about the antidiuretic hormone later and the kidney. We have a whole lecture on the kidney. So I'm not going to go into a lot on this one just yet, but the antidiuretic hormone is just that. If we know what a diuretic is, where we lose water, the antidiuretic hormone retains water. So there's the balance. How do we retain water? And it's usually done through the kidney. So the antidiuretic hormone is secreted from the posterior pituitary when the osmolarity increases or circulating blood volume decreases. So we need more fluid in our blood vessels to move things out to the body, or the blood pressure decreases. So we're not getting as much movement of fluid. Again, we'll talk about all this when we talk about hormones and all of that. So antidiuretic hormone also increases water absorption in the kidney to increase the plasma volume. So let's look at these electrolytes in there. regulation. So the first one is sodium and chloride regulation, and they kind of go together. They have high affinity for each other. It's a salt. It's a salt. A salt is basically two highly attracted elements going together. So potassium chloride is a salt. But obviously sodium chloride is also the salt you eat when you're eating your French fries, right? You sprinkle it on. So sodium chloride highly bound together. So extracellular fluid has sodium. We talked about that. They are the cations, so they're positively charged. Cations are positively charged, and chloride or anions are negatively charged. And so they fit nicely together. So the kidneys, with your hormone and neural mediators, like we just talked about with your antidiuretic hormone, it maintains the sodium in a very narrow range. It's 135 to 145. If you get out of that range, there's some really serious issues. So if we get out of that range, it depends on what's going on with the body as to what that means. So sometimes you might be below 135, and that might be a dilutional. So you have enough sodium, but you have too much fluid, and so it's a dilutional amount. Once you get like really low on the sodium, and when I say really low, it's not that much different from this, but if you're like less than 130, we're talking issues with possible seizures, lots of problems. If you get above 150, we're talking a lot of issues too. So it's a very, very narrow range. Your body does a very good job of keeping it within that range. So hormonal regulation is done through the mineral corticoids. The main one is aldosterone. This is secreted from the adrenal gland, which is the best organ in the body. I think it's just an amazing organ. It does a lot of things. So one of them is it secretes mineral corticoids, and aldosterone is the big one. So what happens is your blood pressure or sodium level trigger the kidney to release renin. Renin is then converted into angiotensin 1. Then ACE, which is angiotensin converting enzyme, is released from the lungs, and it converts angiotensin 1 to angiotensin 2. And that causes vasoconstriction. So it's going to increase the blood pressure. And by increasing the blood pressure, you're increasing the perfusion of the kidney. So the kidney gets a feedback loop to know that I have better blood pressure coming through the kidney. So if your sodium level is off or if your blood pressure is low, this is what happens to increase your blood pressure, to increase the fluid perfusing the kidney. This ACE or angiotensin converting enzyme is important to remember because we have ACE inhibitors as a medication. So what ACE inhibitors are doing are blocking the angiotensin 1 into converting into angiotensin 2, thereby decreasing your blood pressure. So that's what this medication is doing. It's decreasing your blood pressure by blocking the conversion of angiotensin 1 to angiotensin 2. Aldosterone is released from the adrenal gland, and it increases sodium and water reabsorption in the kidney. So those things are reabsorbed. Again, we're going to talk about the kidney later, but it's kind of a brief information on that. Remember, chloride and sodium bond really well together. So wherever chloride goes, or I'm sorry, wherever sodium goes, chloride goes, it makes a salt, and that water will follow. Therefore, the other molecule in the body that contains sodium is sodium bicarbonate. So they kind of compete for sodium, chloride, and bicarb. So if one is elevated, then the other one is low. If chloride is high, then bicarb is low. If bicarb is high, chloride is low. They're inversely related because of their bond to sodium. And this is important if we have a patient that is acidotic and we need to retain bicarb. But that's more than what you need to know. But there are inversely related. So when you see a electrolyte panel and you see chloride is high, you will see your bicarb is low. So let's review a little chemistry. I know everybody loves chemistry, so I'm just going to review this. This is helpful to know for when we talk more about kidney regulation, but it is very helpful to know for acid-base balance. So first of all, and this should go both ways, the hydrogen ion is positively charged, the hydroxyl ion is negatively charged. These bind by the hydrogen ion, and they bind very, very tightly, and it makes water. And water is neutral. So if you have a high concentration of hydrogen ions, then you have a very low pH or you're acidic. And you're like, well, if I have a lot of hydrogen ions, why is my pH a low number? Well, pH is the, excuse me, the inverse of your hydrogen ion concentration. So it's 1 over the hydrogen concentration. So the bigger the denominator is, the smaller the actual number. So the more of this you have, the more acidic the environment. Hydroxyl, the more of this you have, the more basic it is. So the pH increases. So we just talked about sodium binds very well with the bicarbonate, and you get sodium bicarb with an extra little hydrogen here. So this we think of as when, we have a patient who has acidosis, and if we give them bicarb here, we give them sodium bicarb, it breaks down and or it actually binds together, and we get sodium bicarbonate, and then we have this, which will lower the pH. So if we have sodium chloride, like I said, these bind very well together. So if we look at this in the opposite, if we give sodium bicarbonate to a person who's acidotic, so they have a lot of this, it will go into a sodium, breaks down into sodium, and then bicarbonate, and that one breaks down even further into CO2 and hydroxyl. So that's where you get this, which neutralizes this and gives you water. So we're looking at this the back way. So if you take your hydrogen ion plus the bicarb, you get water, but you also get CO2. So if you have somebody who's acidotic, but it's respiratory and they're not getting rid of CO2 like they should, then we're not going to give them bicarb because then that just builds their CO2. So just a little bit of chemistry to help you. I hope it helps you understand when we talk a little bit about acid base, but also it helps with the sodium chloride regulation. Remember, down here, water follows any salt, especially sodium chloride. So once you have sodium chloride bound together and it moves, it's going to take water with it. So this is just a diagram of what we already talked about. So we have here angiotensinogen, and that comes from the liver. Then we have renin from the kidney, and those are converted then to angiotensin 1. Then we have the ACE here from the lungs, and that converts angiotensin 1 to angiotensin 2, and that stimulates the adrenal gland, the best gland in the whole body, and to release aldosterone, and that causes reabsorption of sodium, chloride, and water. Angiotensin 2 also causes vasoconstriction. So for this pathway, we reabsorb water. Well, if you don't have good circulation in this case, then you're reabsorbing a salt and water, and so you become edematous. In this case, also, your blood pressure rises. This is what we want, but sometimes it doesn't help and it makes our blood pressure too high. All right, let me grab something to drink just a second here. I feel like my mouth is dry. Hold on, hold with me. Maybe it's all this talk about water. I'm getting thirsty. I don't know. We have a drink of water here. Apologize. All right. Types of water and solute imbalances. So if, the body does a really good job of trying to keep these balanced, there are some imbalances. So in an isotonic imbalance, we have a gain or loss of extracellular fluid resulting in a concentration of 0.9% sodium chloride. You might recognize that 0.9%. We call that normal saline, right? This is normal saline. This is what the blood is maintained at. So if you give them normal saline, you are giving them the same concentration as what's in their blood already. So you're not going to have a big movement of solutes or fluid when you give them this. The cells don't change because this is the normal state. Um, so you have the cause of this kind of dehydration or imbalance could be loop diuretics, because loop diuretics, you get rid of the fluid, but you also get rid of the solutes. Or in hyperglycemia, it will do this. GI losses for a short period of time, like vomiting and that kind of thing. Renal failure, short period of time. Decreased water intake, fever, diarrhea, vomiting, those kind of things. Now, those are all short term. If these things like hyperglycemia, vomiting, diarrhea, fever go on for long periods of time, then we run into other issues and it switches to more of a hypertonic or hypotonic. So hypertonic means that the extracellular fluid is now greater than 0.9%. So if you did a electrolyte panel, you would see a high sodium level on that. That high sodium level in the interstitial fluids is pulling fluid out of the cell into the interstitial fluid. So the cells will shrink. And this is caused by increase in extracellular sodium or decrease in free water. So if you are not replacing water losses, that will drive up your sodium level because the it's not giving you more sodium. It's just sodium is now concentrated because you remove the water, and that causes the cells to shrink and they're non-functioning, or it can cause the tissue to die. The one we worry about the most is the brain. Hypotonic is where your extracellular fluid is less than zero point 0.9. So now you have more solute in the cell. So water is moving from the interstitial into the cell, and the cells will swell, and then they will eventually rupture. And this is when you don't have enough sodium or you have free water excess. So you are giving the concentration of your IV fluids is very low and it's mainly free water. We don't, everyone's like, well, water is good. Not directly into the vessels, it's not. So if you give too much water, then that water is going to move to where the high concentration of solutes are, which is inside the cell, and that causes the cell to rupture. And you'll see this with hyponatremia. So both very, very scary. So potassium is 4 point, I'm sorry, what we see if we draw a lab, we want it 3.5 to 5. And in the cell, though, it's pretty high. It's 150 to 160. Well, we're not drawing what's in the cell, we draw what's outside of the cell. So what we see is the extracellular fluid on the labs. So this we consider inside the cell. You keep the potassium inside the cell. The daily requirement for potassium is 1.5 milliequivalent per kilo. Imbalance is maintained by increased potassium stimulates insulin release. And aldosterone, which remember is from the adrenal gland, it's a mineralocorticoid, and epinephrine secretion, which activates the potassium transport to liver and muscle cells. Exchanging potassium sodium, I gave you a video to watch, is the ATPase pump. So it will pump potassium into the cell and sodium out of the cell to maintain that balance. So for the balance, that it's stimulated by insulin, aldosterone, and epinephrine. Aldosterone promotes renal excretion of potassium by the distal tubules. So again, that balance is maintained by active transport. Active transport means it has to have an energy source, and that's ATP. So it's the ATPase, or the breakdown. ACE always means breakdown. ATP breakdown for an energy source to pump them across the cell membrane. So the ratio of intercellular balance and the extracellular balance is determined by the resting membrane potential. And this is very, very important. And the video will show you how it's so important for sodium, potassium, but also for other electrolytes to get them where they need to be for different tissues. So this is necessary for transmission and conduction of nerve impulses. So the video will show you that with the brain. Normalizes the cardiac rhythm. That's also in the video. And contraction of smooth muscle and skeletal muscle. So all of this movement of electrolytes requires energy, ATP, and it is essential for the work of all of your organs. Insulin does contribute to the regulation of plasma potassium levels. So what it does is it stimulates that sodium potassium ATPase pump, and it removes potassium from the liver and muscle cells. So it pulls the potassium out of those cells. So if your potassium levels are low, insulin can cause them to decrease more. So that's something to keep in mind when we're talking about diabetics, obviously. So insulin will cause them to decrease more. Now, if you have someone with a high potassium level for whatever reason, renal failure, cell damage, something like that, you can treat hyperkalemia by giving insulin. Hold a minute, second. Excuse me. So if you have a high potassium and you give them insulin, it will take that insulin and it will move it out of the tissues and excrete it out the body. So this is good for those patients, but remember you're giving insulin. And what does insulin do? It pulls glucose into the cell. So it binds to the cell wall, moves glucose into the cell so it can be used. So if you give them insulin, but you don't give them sugar, it pulls all that sugar into the cells and now they're hypoglycemic, and we don't want that. So just remember, if you're going to use insulin to bring down the potassium, you must give glucose with it so it has something to move into the cells. So insulin deficiency During insulin deficiency, potassium transport is not activated to move the potassium to the liver. All right, so if you are a diabetic, then your potassium is not moved into the liver, so your potassium levels may be elevated. You could have aldosterone deficiency, so something's wrong with your adrenal gland, and potassium transport is not activated to move again potassium into the liver. We need all of those with epinephrine. Acidosis. So what happens is the hydrogen ions move into the cells and potassium is removed from the cells. You have to keep a balance of the electrolytes or the charge of each side of the cell. And so hydrogen ions are cations. So are potassium. They're both plus. They're both cations. So for acidosis, hydrogen ions are moving into the cell, forcing potassium out. Strenuous exercise, potassium was moved out of the muscle cells because of, energy, and it also causes cellular breakdown. When cells break down, or at the number six, there's cell lysis, that intracellular potassium is released, and it's a high number. We saw how high it was in the potassium. So that potassium is now released into the interstitial fluid or space. Glucocorticoids, that's from the adrenal gland also, and that regulates your blood sugar. High levels cause excretion of potassium due to that sodium potassium ATPase pump activity. So lots of things can cause your potassium levels not to be maintained. So the kidney, like I said, we're going to talk about the kidney more, but I'm going to talk a little bit about the kidney here. So this potassium is filtered by the renal glomerulus, and 90% of your potassium is reabsorbed in the proximal tubule and the loop of Henle. Principal cells in the collecting duct secrete potassium, but intercalated cells in the collecting duct reabsorb potassium. So it just depends on what potassium we need in the body. If we have too much, we excrete it. So this is regulated by your dietary intake. How much potassium are you eating? Obviously, if you have too much, it's excreted through the kidney. That's why people with renal problems, kidney failure, they have issues with their potassium because they are not excreting the potassium like they should. It also has to do with your aldosterone. We already talked about how aldosterone affects potassium levels. And your urine flow determines excretion. So if you have enough fluid to filter through the kidneys, it will pull that potassium with it. So if you don't have enough fluid, if you're dehydrated, then your potassium could climb as well. Conserving potassium regulation is very weak. So our body doesn't do that great of a job if we need to conserve it. Getting rid of it is easier. You do not have to memorize this. This is just, I thought was a nice picture to kind of help you with some. We will definitely need to know this later. So if you want to learn it now, that's fine. This is showing some of the medications that will affect these different areas. We already talked about, this renin to angiotensin 2, and you see here it talks about some of the medications there. Here it talks about some diseases that affect the adrenal gland, so the aldosterone is not released. Here's some aldosterone receptor blockers. You might recognize some of those. Sodium channel blockers here. So these are some different diseases. So I thought this was a good picture to kind of put it all together. I'm not at this time going to ask you like what blocks your sodium channels, but you should know these, especially as you get farther along in the program. But yeah, I think this picture really is a nice summary of some of the things that affect different areas of the kidney regulation. All right, so we kind of talked about how we retain potassium, how we don't. If we're hypokalemics, these are some of the causes. Renal disease, that's obvious. The kidney does a lot of electrolyte balance. Addison's disease, we'll talk about later when we talk about the hormones. Certain medications, we talked about acidosis already, low insulin, we talked about how that affects blood transfusions. So blood transfusions, you're like, well, how does that affect it? Well, blood transfusion, when you get a blood transfusion, some of the red blood cells will break down and they will give off potassium. And so that's why you get high potassiums as well. Any kind of skin trauma, tissue trauma, again, is giving off potassium because the cells are breaking down. Signs and symptoms of hyperkalemia are anxiety, tingling, nausea, vomiting, kidney damage, and weakness. Hypokalemia, again, renal failure, not regulating our potassium. Diuretics, when it's pulling out all this fluid, it pulls electrolytes with it. You know, when you get to pharmacology, you'll talk about the different diuretics and where they affect in the kidney, especially in the nephron. And that will show you, whether they're potassium sparing or not. We always talk about those kind of things. If they're not potassium sparing, the potassium is lost with all that extra fluid. Cushing syndrome, that kind of goes along with the Addison disease, which we'll talk about later. Medication, GI loss, if you are vomiting profusely constantly, you're going to lose a lot of electrolytes that way. Low intake, you're just not taking in that much potassium. That's very difficult to do, not taking enough potassium. But if you have a really poor diet, that would happen. Insulin excess or alkalosis. So those are opposites. Manifestation is weakness, skeletal muscle weakness, smooth muscle atony, cardiac dysrhythmia, and confusion. So now calcium and phosphorus, they kind of go together. They're regulated it starts out with the parathyroid hormone is stimulated, and that stimulates reabsorption of calcium in the distal tubule and it inhibits phosphorus. I don't know why I have an H there. Phosphorus reabsorption. Obviously, this is in the bones. Vitamin D cholecalciferol. It increases absorption of calcium and phosphorus in the small intestine and enhances bone calcification and kidney mechanisms, as we talked about before. Calcitonin is produced by the thyroid gland and it decreases calcium levels by inhibiting activity in the bone. So it has to do with the parathyroid hormone, it has to do with the kidney, it has to do with the thyroid gland, the regulation of these two electrolytes. Typically, not always, but typically, if you have a high calcium level, you have a low phosphorus level. If you have a high phosphorus level, you have a low calcium level. They need to be in balance. Ionized calcium, which is not bound to plasma proteins, is the most important function of the body. So you may have calcium, but it might be bound to proteins, so it's not active. So ionized calcium is what we use in our body. That is important when you're doing calcium levels. So if you order a calcium level, it may not be super accurate as to calcium levels. So we like to get an ionized calcium if we're really worried about the calcium levels. And that will give us a better indicator if we have that free calcium to work in the body. We do this a lot on babies because babies don't have many calcium stores. So that's why breast milk is high in calcium so that they can get that calcium after they're born. It's important to remember that if you're doing IV fluids again, that those small children, you do have to give calcium in the IV fluid, which can be quite detrimental to veins. So just have to keep that in mind. If you have a low calcium level, the body will start to leach calcium, but it'll also leach phosphorus, but it will leach calcium from the bone, with alkaline phosphatase. So alkaline phosphatase is if you have do another electrolyte panel and you see the alkaline phosphatase is elevated, that means that it is pulling the calcium to keep it in a steady state from bone. So it's weakening the bones. Hypercalcemia, see again, we got the renal failure. The kidney is very important with electrolyte balances. Medications such as the thiazides will cause hypercalcemia. Excess intake, taking too much calcium, excess vitamin D. We'll have, I know some people who take like a lot of vitamin D, and I've never known them to have problems, but it is something to keep in mind. Vitamin D is not water soluble, so you take too much vitamin D and it will start to store in the fat cells, and then you can have issues with your calcium levels. Hyperparathyroidism, prolonged immobility will cause it because the calcium is leaching out of the bones, and a low phosphorus. Remember, if one goes up, the other one goes down. Manifestations, confusion, lethargy, headache, decreased reflexes, EKG changes, hypertension, polyuria, because you have all these calcium coming through the kidney and then it's pulling water, so you're urinating a lot. Dehydration, nausea, vomiting, and abdominal pain. Just to talk about that calcium phosphorus balance again, remember it's pulling out of the bone, the calcium and phosphorus, and alkaline phosphatase is not selective. It's not selective, so it'll pull both out of the bone. So if you have a low phosphorus level, it will pull both. So then you'll have a high calcium level to standard or get your phosphorus level in check. Hypocalcemia, renal failure again, alkalosis, medications, too much phosphorus, the balance. Diarrhea, pancreatitis. Manifestations are anxiety, confusion, lethargy, muscle spasm, laryngeal spasm, EKG changes, hypotension, and increased bleeding. For hyperphosphatemia, renal failure, that's pretty much a given, right? Hypoparathyroidism, adrenal insufficiencies, which we'll talk about these in our endocrinology lecture, hypothyroidism, medications such as laxatives, cellular damage, potassium deficiency, hypocalcemia, acidosis, and it's similar to hypocalcemia because if you have hyperphosphatemia, you probably have hypocalcemia. And hypophosphatemia, renal failure, hyperparathyroidism, malabsorption, vitamin D deficiency, alcoholism, and alkalosis. So again, hypophosphatemia looks like hypercalcemia because you probably have both. Magnesium. This is an intracellular cation. Regulation is balanced by the kidney and the small intestine. Kidney will conserve magnesium if your levels are low. So again, if you have renal failure, your electrolytes are going to be a mess. This will interact with calcium because calcium is its antagonist. So again, those three electrolytes, magnesium, phosphorus, and calcium have to be balanced. Improve vascular muscle, smooth muscle tone, and it reduces dysrhythmia. And why does it reduce dysrhythmia? Because it is blocking the calcium level. It improves metabolism of lipids and glucose. So magnesium, you hear it more and more nowadays because of its ability to help you sleep. So I think of it as like a smooth muscle, keeping it kind of at a nice, even pace tone. So it's not irritated. And so if you think about like women who are pregnant and go on magnesium, it is decreasing the contractions or the tone of the uterus. Acid-base balance. I just went over a couple slides with this because you've probably had this in your undergrad. So just kind of a little bit of review. Again, we have our chemistry here, how water and carbon dioxide bind to make, well, actually, it starts down here. We have oxygen coming to our hemoglobin. It gives our hemoglobin uh, oxygen binding to the hemoglobin plus hydrogen ion, which then binds with the bicarb, which causes the breakdown of water and carbon dioxide. So it's done in the hemoglobin. So we do have chemoreceptors increase or decrease our pH and our CO2 levels. These are located in the breathing center of the CNS, in your aortic bodies, they're in the aortic arch and the carotid bodies. So they are picking up those sensors in those areas, your pH and your CO2 levels. Based on that, it will change your breathing rate. So it will increase your breathing rate to get rid of extra CO2, and carbonic acid raises the pH. It's a very fast process, but remember it can build your CO2 as well. We looked chemistry already on that. The kidney will secrete your hydrogen ion and retains the bicarb. So the breathing rate will is compensating for your levels, but so does the kidney. The kidney is very, very slow. It won't kick in for a while. So that's why the lungs will do it first, and then um, excuse me, the kidney will kick in. We don't really want the kidney to kick in because the kidney doesn't do a very good job. It retains that bicarb, but what it does is gives off more CO2. So it makes the CO2 rise, which gives us respiratory issues. So we really don't want the kidney to start its process. It's kind of like doesn't really help that much, I would say. All right. I think this is the end. Yes, it is the end. So if you have any questions, let me know. This week we have a quiz, so we do not have a review session. If you have any questions, please let me know. You have a good day.